Here we go. Keep going here, and some people will continue to log after we start. Thank you for attending this evening's webinar. The first time the Bureau of EMS has developed an online update for all of our EMS providers statewide, all 60,000 of you. As we move forward, we will be looking at ways to improve how updates are pushed out to you. The Bureau is also revamping the Regional Faculty Program, which will allow us to utilize regional faculty locally and more often in the future. As we new project, there will be some bumps along the way, but hopefully the successes will outweigh the bumps in the road. We look forward to your constructive feedback as we move forward. As you may know, we had some issues with our first webinar with audio. That's why we limited this session at the number of people that could participate. And because of that, we are going to have a recorded version of your webinar, either tonight's webinar or a separate webinar that we're going to do. And we'll email the link out to the recorded version to everybody who has signed up for any of the webinars. Plus, we'll send it out to the REMSCOs, program agencies, and as many listservs as we can. The recorded version will be the same as this evening's is. You'll be able to register for the recorded session, and you'll do a quiz just like you will with this one here, which we'll talk about in a couple of minutes. So that way your CMEs get to you and you'll be all set. So the recorded version will also be downloadable according to WebEx. As long as it is, you can also download it and present it to the larger crowd if need be. This evening's update will cover the new spinal protocol that has been approved by the State Emergency Medical Services Council, SEMSCO. We'll also cover an update to the hemorrhage control protocol that is in the final stages of approval by the State Emergency Medical Services Council. This approval should come at their next meeting in December. We wanted to be able to get you the information now in anticipation of the protocol being approved. And moving forward, we'll be looking to do annual updates, similar to as we're doing now, but only once a year. The plan right now is to do it sometime in the late spring. That way, instructors can get everything ready for their fall courses that are coming up. Of course, any urgent updates will be sent out as they have in the past, instead of waiting for one update statewide. There is a 25-question quiz, which will be available after you complete this webcast. You'll be able to click on the same link you used to enter the webcast, and get the link down towards the bottom of the page, and it'll say test. Email today or tomorrow gives you a separate link to take the test. So 2 weeks to complete the test. And completed the test and scored at least 80%. You will get a certificate via email from us probably around September, in the first week of September. But you'll also get an email from WebEx immediately following the quiz with your grade, and that way you can have that to make sure that you did pass the quiz and show anybody for your CMEs that you need before you get your certificate. There is a sales component that needs to be completed and can be done locally. Please reach out to your agency training officer or your regional EMS council to find out where a local sales session may be held near you. Who are participating in the CME Refresher Program should first reach out to the CIC that is affiliated with their program to see if they can assist you in the skills portion. We placed an Adobe PDF copy of today's webinar, all the PowerPoints, including other information under course material. The registration link that you receive will lead you to that section that says course material. You get information to get a later date. Also included in that course material is the actual protocol we'll be discussing tonight, T8, the spinal protocol. We have the respiratory protocol as well, and frequently asked questions that many people ask. Refresher requirements. This stuff is approved for 3 hours of New York State CME. It can be utilized for preparatory or trauma core or additional hours as well. Keep a copy of this webinar's PDF in your CME file at your agency. Keep a certificate that you're going to receive from us in September, as well as a copy of the email you received from WebEx with your quiz made on it. The presentation will not only review the specific protocols, but also discuss some of the best practices that have been learned from around the country. I mean, we've got about 256 different people logged in. I know we've got some areas like Good Samaritan Hospital and some other areas that have got large number of people watching this at the same time. So it's going to be difficult for me and probably impossible for me to respond to your chats if you do send me a chat. So I will look at those chats later at the end of the broadcast and try to get to some of your questions. As with anything, there's always some legal stuff we have to take care of. Any liability, the department doesn't have liability for any products or information that we're discussing here. The department is not endorsing specific manufacturers' commercially made items or non-commercially made items. There's some links that will be available to you at the end of the sessions, and we don't have any control over those links. Once we put them in the presentation, they may have changed, or there could even be some pop-up advertisements that we were not aware of and were not present when we did the search and gave you the links. So I'll talk about the BLS hemorrhage protocol first before we move on to the spinal. A group or a tag from State Emergency Medical Advisory Committee, CMAC, was headed by Dr. Carl Goodman from Suffolk County. In conjunction with STAT, the State Trauma Advisory Committee, we're able to develop a new protocol and revise the hemorrhage control protocol that will hopefully be approved in December. Sending you this educational update a little ahead of time so you can be prepared ahead of time, so when the protocol is approved in December and we ship it out, you're all set. There won't be any other additional training for that. So in the meantime, the current protocol is still active. All right, why are we changing the hemorrhage protocol, or any of our protocols for that matter? With most changes in EMS, which come from lessons learned, military experience, and through current events that happen. No one can argue they're seeing more and more mass casualty incidents where tourniquets have saved lives. Tourniquets are being supplied to all military personnel, many police officers, and in some instances, civilians. There are commercial products that have been designed to be used by the public, for example, school teachers, for mass shootings, and many of these kits do include tourniquets. While the current New York State BLS protocol does include the use of tourniquets, our research has shown that many providers are still very hesitant to use them. Some trauma centers have reported that providers saying they can't use a tourniquet or they can't only use it under very limited circumstances, such as the patient will die without it. That actually is not true even with the last protocol, but it's going to be more emphasized with this protocol. Our hope is that this presentation will better educate our providers statewide and offer them the ability to have increased knowledge and then thereby taking better care of their patients. Just going to make sure that we've still got audio going. Somebody can let me know that. There's a couple of people who are saying they don't have audio. Okay, but a few people do have the audio. So with the patient assessment, we've been taught airway before breathing, before circulation. With an 10 AHA changes, we began to utilize the CAB sequence, circulation, airway, and then breathing. We all know that in most cases, ETs are done simultaneously. Of course, we are in a testing environment where sequential steps can be easier to grade. When we arrive and see a patient with severe bleeding, they are awake and talking to us. We don't really systematically and sequentially begin with A, then B, then C. We're really on automatic pilot. During the education process, it's easier to learn things sequentially until the student is able to reach the synthesis stage of learning process, and it becomes almost second nature to them, which are you now. This is difficult. Studies shown that medical personnel of all different instances and certifications tend to err when estimating blood loss. Blood loss tends to be overestimated at low volumes and underestimated at high volumes of loss. If there are signs of arterial bleeding or life-threatening bleeding, you take care of it right away and defer further assessment. You can do more than one thing at a time. Controlling bleeding while talking to your patient allows you to assess their airway. Delay treatment to stop the bleeding. It's a must. Be ahead of time, just as you are with all the rest of your calls. What by life-threatening bleeding, you need to take care of it immediately. That's the time to go back and find your PPE, your ambulance, or your vehicle. Clothing can disguise blood very well. You need to expose the area that is bleeding so you can do an accurate assessment and develop a strategy to control the bleeding. You don't place your hand over the clothing and find out that there's a sharp object lying underneath the clothing. Dressings will do little to control any bleeding if they're placed over clothing. Once you expose the site, you can then determine the severity of the bleeding and possibly any other associated injuries in the area of the bleeding. Applying direct pressure with a sterile dressing will control most bleeding that we've come in contact with in EMS. However, if it is severe or arterial, you need hemostatic dressing or even a tourniquet as your first line treatment. So as you can see, we're starting to move the tourniquet up higher in our treatment to the first line treatment if needed. Remember, hemostatic dressings need to be laid directly on the wound site or they will not work. Follow the manufacturer's instructions for the hemostatic dressings that you use. Injectable solutions and foam products are included in this protocol. If it is your first line treatment, remember that you still need to apply dressings over the site of the bleeding if possible to detect it. Process of controlling the severe bleeding. You can move on to the rest of your assessment. Don't sidetrack with the obvious. The obvious or the unseen problems could hurt your patient even more. Airway, breathing, circulation are all adequate. Assess circulation and neurological status above and below the bleeding site is an important part of your assessment. Elevation and pressure points have found to have little to no effect in controlling bleeding, in part because it can waste valuable time if a tourniquet is needed, and pressure points are difficult to find and very difficult to maintain. So yes, elevation and pressure points are now out of the protocol. Instances where direct pressure and pressure dressings are not working, you need to be prepared to move to the next step, apply a tourniquet. You cannot remove the dressings that are directly in the surface of the wound site. This can dodge any clotting that has already taken place and thereby increasing the bleeding. You can add additional dressings on top of the dressings that are soaked through. Remember though, this is primarily done to soak up any of the blood, but has little effect on controlling the actual bleeding. Studies have been done, mostly in the military environment, when tourniquets are used in a timely manner, patient outcomes are improved. Studies have also shown that there are little to no complications with the use of tourniquets. The positives far outweigh the potential negatives. The tourniquets that proved to be the most effective were commercial devices, especially the Combat Application Tourniquet, or CAT, which many studies have found to safely and effectively occlude blood flow with a low incidence of adverse events. That is only one of many FDA-approved commercial devices. Many times, non-commercial devices don't perform adequately as a tourniquet, but more as a ligature device, thereby occluding the blood flow, but only slowing it down. For this reason, it may be more appropriate to use a commercial device instead of improvising. You might tool for the job, but you know how to improvise if that tool is not available to you or not working appropriately. However, this does not mean you have to go out and buy an expensive tourniquet. With this, you may be able to accomplish bleeding control with non-commercial devices, but you need to practice and be very sure what device you're going to use is going to work, that you're able to assess it, completely stop the bleeding by that device. Commercial devices were developed by or in conjunction with the military and are able to be self-administered, which is what is needed during a combat incident. Typical response teams and police departments are utilizing these tourniquets quite often and have been given to most of the officers that are out there. This is an example of just a few of the devices that have used as tourniquets for years. No matter what device you use, make sure you know how to use it according to the manufacturer's instructions that you've practiced using it. The device at the bottom right of the slide is actually a device that was used during the Civil War. Although the exact number of surgeries performed during the Civil War is not known, approximately 60,000 or 3/4 of the surgeries were to perform amputations. Without the use of a tourniquet, many soldiers would have died. 20,000 soldiers did die during the Civil War, but thirds of them died from disease and blood loss from their wounds. Questions occurring regarding where the placement of the tourniquet should actually go. At this point in time, we're going to use the rule of thumb of placing a tourniquet 1 to 3 inches above the side of the bleeding. If that happens to be over a joint, then you would go 1 to 3 inches above that proximal joint. Studies do use the placement of high and tight method to place a tourniquet. Place it as high in the limb as possible, proximal to the trunk of the body. High and tight is used more often in an unsafe and tactical environment because it may be safer for the provider to apply the tourniquet. The goal is to control massive bleeding within 60 seconds. Although there are key differences in the training approach, providers can meet the goal of tourniquet placement with arterial occlusion within 60 seconds only through repetitive and supervised training application of each selected device that they're going to use. So the key here is practice the devices that you have. Short video here, and the sound may be off a little bit on this video. You may see the sound lag a little bit depending on your internet connection, but you'll get the point of this. We only have 2 videos in tonight's session anyways.
Hello, I'm Dr. David King, a trauma surgeon at the Massachusetts General Hospital, assistant professor of surgery at Harvard Medical School, and surgeon for the United States Army. This video is intended to provide instruction on the appropriate way to apply a tourniquet for massive lower extremity bleeding. To identify the wound and loop the tourniquet around the limb 1 to 3 inches above the wound. Importantly, the tourniquet be placed over clothing. The step is to ensure that the tourniquet is looped through the buckle twice. The step is to tension the tourniquet. This is done by vigorously pulling on the free end of the tourniquet and tightening it such that a finger cannot be interposed between the tourniquet and the patient's skin. The fourth is to twist the windlass up to 3 times or until there is cessation of bleeding. The fifth step is to inspect the wound to ensure there's no ongoing bleeding, to palpate for a distal pulse, which should be absent. To achieve hemostasis. Inspect if there's ongoing bleeding, ensure there are 3 twists in the first tourniquet, and apply a second immediately adjacent to and above the first. Once the tourniquet is in place, it should be up and tight until evaluated by a surgeon at a hospital. Tourniquets can save lives on the battlefield and in the homeland. This instructional video provides the basic necessary information to properly apply a tourniquet to massively bleeding wounds. In my experience, a properly applied tourniquet can save lives. This is a step that anybody can master with the Heimlich maneuver or CPR.
Yeah, music playing in the background as you're putting the tourniquet on, or else it won't go on properly. I know the music does make that video, but that's just an example of showing you how the devices should be in place. You can see I checked the patient afterwards to assure that they had the proper tension of the tourniquet and so forth. So that was a quick video showing you on that. Tourniquet application, we're going to go over those steps again here. Ensure that the tourniquet is tight enough to occlude distal pulses. You should also recheck to make sure that the tourniquet is not loosened and the pulses have not returned distal to the tourniquet. Tourniquets are not a place it and forget about it device. Keep the tourniquet and side of the bleeding visible with no clothing, blankets, or sheets obstructing your view. Do not remove the tourniquet or dressings to reassess bleeding. Once it is applied, you need to assess that it is working correctly. Check distal pulses. There should be no pulses distal to the tourniquet. Make sure you know where to find the appropriate pulse for the appropriate limb and location of where you place the tourniquet. Locate pulses can be tricky. You should be able to practice this on multiple patients and other people to get a better understanding of where and how to find these pulses. If you still have distal pulses, you may need to tighten the tourniquet a little bit more or rethink your placement of the tourniquet and apply a second tourniquet. One of the most common tourniquet application errors is not getting the tourniquet tight enough, usually because we don't want to cause pain to the patient and want their ready. You need to make sure that it does include all distal pulses. Standard documentation that you apply a tourniquet on your patient is still writing it on the patient's forehead. That's internationally known, but you could also use 2 or 3 inch wide tape, put that on the forehead with the information written on the tape. That might be a little bit better. In this example, we have T2 1834, which means that the tourniquet was applied at 1834. You can also place the location on that if you like. The only problem with placing the location is if you put multiple tourniquets on, they may not find the second tourniquet. Since this is really a universal designation that the patient has a tourniquet in place, you should always use it. You also need to document all information in your patient care report, and where documented the tourniquet placement on the patient's body. To apply a second tourniquet, either you've still got distal pulses and you can't tighten the first one enough, or you've still got bleeding. It should be placed proximal or above the first tourniquet by approximately 1 to 3 inches. Follow the same application procedure and reassess for distal pulses and how the bleeding is controlled now. This brings us back to the high and tight method. If you utilize the high and tight method, you aren't going to be able to put a second tourniquet on above the first tourniquet without some side effects. But again, we're going to get that hammered out for you at the December SEMSCO meeting and the final protocol of which way they decide to go with it. In this picture, this shows the approximate location of where you should place the first tourniquet and where the second tourniquet should be placed in relation to the first tourniquet. This is an example of an amputation at the ankle. Because of the fact that there are 2 bones in the lower leg, it can be more difficult to control bleeding there than it would be if the tourniquet is placed on the upper leg above the knee, with only 1 bone. But this does not mean you usually go directly to the upper leg. It does mean that you need to keep a close eye on the effectiveness of the first tourniquet when it's placed on the lower leg. Tourniquets should not be removed in the field by EMS providers. Only after reaching definitive care or on orders of your medical control physician should you remove a tourniquet. This rule applies to those patients who will reach definitive care within 2 hours of the application of the tourniquet. If it will be more than 2 hours, medical control should be contacted for advice. If a tourniquet is removed and replaced with a pressure dressing, you should leave the tourniquet in place but loosened or tightened to not restrict the blood flow, and you need to reapply the tourniquet later. Also, if a tourniquet is removed, it should be removed slowly to reduce the chance of severe bleeding returning. For all of us old folks who have been around for quite a while, it's the same concept as we use with the mask pants. When you deflated the mask pants, you did it slowly so the bleeding or the blood flow returns slowly. If your patient needs a tourniquet, they may be highly susceptible to hypotension. Make sure you continue to reassess the patient and their vital signs. The vitals should be taken at least once every 5 minutes. The tourniquet and distal pulses should also be a component of your vital signs. close attention to the trends in the patient's vital signs. Is the pulse rate faster each time you take it? Is the blood pressure showing any signs of lowering each time you take it? Watch for subtle hints of hypoperfusion. Whether your patient has an isolated extremity injury or multiple trauma, make sure you know a triage protocol to ensure that the patient is taken to the closest, most appropriate hospital, for example, the trauma center. And of all, document. That's the universal tourniquet documentation, fill with patient information, including your trended vital signs, so you can show the physician and the staff whether or not the patient is starting to decompensate. Some considerations. Many of these patients who require tourniquet may need to have advanced life support interventions. The most common intervention may be fluid replacement through IVs. However, your patient will most likely be in quite a bit of pain, so pain management needs to be considered. A tip in and of itself can cause quite a bit of pain, let alone just the injury that caused the severe bleeding to begin with. Another consideration is for compartment syndrome. Although really rare, tourniquets can cause compartment syndrome, especially in long-term tourniquet usage. Tourniquets are usually limited to 90 minutes of application. Advanced life support providers should be called for patients who may have an extended transport time or application time to monitor for compartment syndrome. The device is being manufactured all the time and sold commercially that in controlling severe bleeding in one form or another. There's just an example here of some, including the junctional tourniquet and the skin closure devices. The protocol allows for these devices to be used only by formally designated tactical medical response teams who are designated through their regional remit. Next, we're going to talk about dialysis patients, which can give us a little bit of a different complication here. We're seeing more and more patients on dialysis for various reasons. There are more than 500,000 people currently undergoing hemodialysis treatment. The aging population is anticipated to have a large impact on the increase of dialysis patients as the risk of end-stage kidney disease increases with age. Patients who need dialysis on a routine and long-term basis will most likely have an arteriovenous fistula, also known as an AV fistula. This is usually found in the forearm. The AV fistula connects a vein and an artery together and causes a stretching or dilation of the newly formed vessel. Fairly rare, but the most common complications of AV fistulas is bleeding from the hemodialysis site, and the bleeding from the site can be life-threatening. Patients are trained to check the blood flow through their fistula on a daily basis. This is done by touch and sound. You put your fingers over the fistula, you should be able to feel the motion of the blood flowing through it, just as you do if you're taking a patient's radial pulse. To look for blood flow, use a stethoscope and place it flat on the fistula. The century here is called the bruit. Any in the pitch may indicate a clot or a narrowing of the fistula. They may change from a whooshing sound to more of a whistle-like sound if it is becoming narrowed. If you're concerned enough to evaluate the fistula, and if the patient has assessed themselves on a routine basis, you may wish to have the patient assess themselves again to determine if there are any changes in what you're hearing or feeling. Pressure with a sterile dressing is usually sufficient enough to control most of the bleeding from a hemodialysis site. In these patients, tourniquets are really used as a last resort and only for life-threatening hemorrhage because of the high risk of thrombosis and damage to the fistula. But still know that you may have to put a tourniquet on these patients. Here's an example of an AV fistula that is ruptured and now bleeding externally. The higher pressure of the blood flow. Applying direct pressure to the site should stop the bleeding, but then it may require the placement of a tourniquet. Additionally, some of these patients may be taking a medication to thin their blood, which will make it even more difficult for you to gain control of the bleeding. You are going to place the tourniquet on these patients. Try to get the tourniquet above where you see the AV fistula. Since this is in the lower arm, you're better off placing the tourniquet above the elbow. Now let's take a look at the actual protocol as it stands today, and hopefully will be approved at the December meeting of the SEMSCO. Radar, applying direct pressure and or pressure dressing, no major change there, and assumes that you've already removed any clothing or anything around the bleeding site, and you've inspected it to find what kind of bleeding you have. Direct pressure on the left side here is effective in controlling bleeding. We'll go to that side first. The airway and breathing are adequate, and there's circulation, of course, because you've already been checking on that. Because it's bleeding, you've kind of used the CAB instead of the ABC. After you've assured airway, breathing, and circulation, and you're using pressure dressing to control the bleeding, transport according to your BLS on a triage protocol. And most of these patients, they're going to go left side here, are going to be most of the patients that we do see, and may not need a trauma center. They just may be able to go to a community hospital. So this is the reason for most of your patients that we're going to see. But the next slide, we're talking about direct pressure is effective or impractical for whatever reason, maybe a hazardous area, unable to get to the bleeding site if they're entangled in a vehicle. For whatever reason, hemorrhage can't be controlled. So they're going to look at whether or not the wound is amenable for a tourniquet placement, the wound not amenable to a tourniquet placement. Then maybe a junctional tourniquet or a skin closure device can be used if you are approved as a tactical response team. Go and apply the tourniquet, and you see here it says high and tight, but we're going to continue to use the 1 to 3 inch above site at this point, 1 to 3 inches above the proximal joint, if it's going to be right around the joint area. And if that doesn't control the bleeding, apply a second tourniquet if that has not been controlled. Again, tourniquet goes just above where the first tourniquet is. And this is really where the discussion is going to be happening in December of whether or not we're going to use high and tight or that 1 to 3 inches above the location. Can apply hemostatic dressings on the right side here. If you are originally approved and you do have hemostatic dressings, that can be an option that you can use along with your direct pressure initially to help control the bleeding. As the other side went, assure that there's airway, breathing, and circulation is adequate. This is for hypotension, and continue to assess during transport. Taking your vitals at least every 5 minutes and transporting to the appropriate hospital. Note boxes at the bottom. We've already discussed most of this information here already, but it's transporting to the appropriate facility, maybe a trauma center, maintaining the patient's warmth, watching for hypoperfusion, documenting everything. If you're a tactical response team for general kits and cutaneous closure devices. Talking about if the tourniquet is placed, the patient may require narcotic analgesia, as we discussed, and hemodialysis access sites. There's one question on here from somebody who did say it, where the placement is going to be, if it's going to be artery proximal to the wound. It's going to be above the wound site. And again, we're talking about extremities at this point. It's going to be above the site, closer to the trunk of the body, 1 to 3 inches above the site. And the 2-hour window is kind of a general idea. Most tourniquets are not to be left on for more than 2 hours. But if you really think that it's going to be an extended time of 90 minutes or more, go to medical control and get their advice, because they may want you to loosen it a little bit occasionally to try and prevent some of the side effects, such as compartment syndrome. It's kind of a general number, but and mostly sure they're never left on for more than 2 hours. That's the cutoff point, no pun intended, but 90 minutes really should be what you're looking at on a window here. And I think in most cases, we're looking at far less than an hour for patients that we're going to be dealing with them. That's going to use or control bleeding from the femoral artery. That's really going to be direct pressure, and You can use it if you're approved regionally, a junctional tourniquet, which is used primarily for the femoral areas and areas that are very close to the trunk of the body and the joint areas. For the most part, that's going to be direct pressure throughout the transport. Notes here, these are some websites and articles and studies that we use for this presentation, as well as was used during the TAGS report, and some additional resources for you to look up afterwards. And again, this is all on the PDF version of this webinar that you can look at later, and you can feel free to look up this information on there. So we're going to move on now to the spinal injury protocol. So one other question that came up here real quick on the hemorrhage, it says, is any of this based on PHTLS? Yes, to a degree it is. PHTLS information was used by the TAG. We also used a lot of New York State data from trauma centers. Actually, New York State has some of the best trauma data in the country, if not the world. And we've had a lot of other states come to New York State to access our trauma data, because we have a very good trauma registry that has a lot of good information on it that even the CDC and PHTLS and other places don't have. But this pretty much does follow PHTLS with some small variations. So we'll move on to the spinal protocol here. And as with the hemorrhage protocol, this was done through a TAG composed of members of the CMAC. It was by Dr. Joe Bart from the Wyoming Erie Regional EMS Council. State Trauma Advisory Council also had input on this, and IMSCO went ahead and approved changes to the protocol. So this protocol we're going to discuss now is actually all done and approved. The objective, we're going to, once done with this, you'll be prepared to utilize the updated New York State BLS protocol that incorporates the use of spinal motion restriction versus the traditional spinal mobilization that we're all used to. More philosophical change for a lot of people. This is a huge change in philosophy for most of our EMS providers out there, especially those of us who have been around for a long time. We've had reporting pounded into our heads for over 40 years, and now we're going to be looking at spinal mobilization in a much different way and a better way. So more than ever before, we need to really keep an open mind and learn from the studies and the medical data that the TAG reviewed and being care providers. The objectives here, I'm not going to go through all of these. These are primarily here for you to use because of your semi-renewal, so you know what objectives that were actually covered. CIC can review these objectives to ensure that you can put what you're supposed to. We are going to have psychomotor objectives. That's the skills stations. They're going to be done through a skills portion to the CME. That document is also in the course materials section that you're able to get back on later if you want to through the registration or the webinar link. And that is not a testing station. That is a scenario-based type training. It's a training. They're in a format that may look like a practical skill station, but it's not testing. It's supposed to be done much more different, laid-back environment. And we'll talk more about that later. Objectives. And there's the affective objectives. Again, this is perhaps the most difficult portion of the CME, is really getting provider to find and around what spinal motion restriction is versus spinal mobilization and why we're actually doing this. There's a lot of articles out there over the past few years about this. Some places have already initiated this. States that we've been working with initiated this probably over the last year or two. We've kind of learned from their mistakes and their good point they've had throughout implementation and put this webinar in our protocol as well. So, are we going in time? Well, to a certain degree, yeah, we are. But we're going back in time because of the scientific evidence that we didn't have back then, but that we have now. We're not just changing the protocol, we're again changing mindset, a technique that has been reinforced in all of us for over 40 years. So many EMS providers, it will be an uphill battle to change the way we have done things for decades. So research has shown that it takes up to 17 years for EMS providers to fully learn, embrace, and practice a new Hill. In New York State, we studied this when the critical care trauma curriculum was rolled out in the 1980s. At that time, we found that it took a minimum of 5 to 6 years to get all EMS providers on the same page, utilizing the techniques and information that were in that curriculum. So hold on. Don't your backboards yet. Use them for sliding boards or go surfing with them or make fun of them just quite yet. We're going to be using them in some aspects. For those of us who have been around for quite a while, we also know that it tends to repeat itself, and just because something goes away doesn't mean it won't come back at a later date. Ice pans and some other things that we've had over the years. So hold on to your backboards. Don't throw them in the industry quite yet. The previous protocol in 2008 rolled out with a PowerPoint presentation and some ancillary documents. However, it was found that a lot of the training changed quite a bit at the local level, which caused a lot of confusion amongst the providers. The protocol at that time was based on science that was available to us in 2008, and a lot of help from the state of Maine's EMS medical director. We had a successful spinal program after some initial bumps in the road. That protocol from 2008 was to reduce the emphasis on mechanism of injury and shifted more to the patient's complaints and your assessment findings. They should have reduced the usage of spinal mobilization in theory. However, the protocol actually had little effect on provider practice, and patients were still being spinal immobilized, if not more than they were before. Why? Well, there were a lot of QA and QI committees that were still requiring spinal mobilization based on mechanism of injury and other factors. Providers were afraid of being sued if they used spinal mobilization, and we know how the state New York is in society right now. So a lot of providers just said, you know what, I'm playing safe and just put them on the backboard. But as we're going to discuss down the road here in this presentation, that could actually be doing more harm than good. The emergency room staff did not understand the reduced usage of spinal mobilization by EMS. This is why it's very important for the regional councils and your local medical directors to keep an open line of communication with your local emergency departments so that they're aware of the changes that are coming down through. It's difficult for us at the state level to reach out to all of the hospitals and the emergency departments. We don't have regulatory authority over them. So this is really done at the local level by physicians, the REMAC, the REMSCOs, and even you guys reaching out to the nurses and physicians at your local hospital. Also, there was just an overall lack of communication between providers as well as instructors and medical directors, which caused very little changes in that 2008 protocol. Hopefully, a lot of that will be learned through this presentation and this protocol. We've been spinal mobilization for a very long time. So why all of a sudden are we stopping? Well, there are several studies performed on the use of backboards, and some results are seen here on this slide. We've ever had a patient say that they were comfortable on a backboard, especially after suffering a traumatic injury. Sometimes it's just been easier for EMS to put the patient on a backboard to them from point A to point B and get them on your stretcher. Studies are showing that the risks and costs are outweighing the positive outcomes of these backboards. One patient is on a backboard, in many instances, would be left on the backboard for several hours until the hospital cleared their spine injuries and removed them from the board. This is especially bad for our geriatric patients who can begin to develop skin ulcerations within minutes due to the pressure of their body against a hard surface such as a backboard. Ulcerations on patients can lead to sepsis and even death, not to mean that they're extremely painful. Over 97% of cervical spine x-rays showing no spinal injury, and only a fraction of the remaining 3% have an unstable spinal injury. We are subjecting most of our patients to unnecessary radiation. The costs are very high to the healthcare system, with costs exceeding $175 million annually just for these x-rays. Now, you say that this is a problem for the hospitals and not for EMS. But we, EMS, are a part of the total healthcare system. We are not fixing a hospital problem. We are working together to assure good total patient care with positive outcomes for our patients. We need to remember, first, do no harm. Just because we saw one patient have an unstable spinal injury doesn't mean we have to backboard all of our patients. We become educated, thereby becoming better patient care providers. The new protocol will hopefully be better understood and more appropriately used than the previous protocol. It's that are reflected in the 2015 protocol. Results from the review of several studies, as well as the NEXUS, National Emergency X-ray Utilization Study criteria, and the work of the UNSCO TAG that has been reviewing the current science, research, and literature that's been out there. The NEXUS study has been out there for quite a while, and actually most hospitals are very aware of the NEXUS study. The criteria now allows for the use of a cervical collar without utilizing a backboard, so introduces the concept of spinal motion restriction. We need to start thinking outside the box more than ever before. So you will have a patient that will come to the emergency room in a cervical collar, probably, most likely, not on a backboard. Very new for us. So what's spinal motion restriction? Well, immobilization is the act of securing a patient to the spine board, either short or long, and not allowing any movement. Spinal motion restriction is not restricting all patient movement, limiting the patient movement to reduce excess movement of the spinal column. So we're trying to stop them from totally moving. We're trying to stop any gross movement that may increase the likelihood of injury to their spinal column. The backboard can be utilized to move the patient to the stretcher if necessary, but the patient should be removed from the long backboard prior to initiating transport. Removing the patient from the long backboard will be discussed later in the presentation. Spinal motion restriction is designed, again, to reduce gross movement of the patient, and in particular their spinal column. With proper spinal motion restriction, you may still have some movement of the patient, but it should be limited to prevent further or additional injury. Proper application of a spinal motion restriction will reduce the negative effects caused by traditional spinal immobilization, while providing appropriate and necessary care to the patient who made a spinal injury. Yes, we were causing injuries and discomfort to the patients that we were immobilizing many of the times. And a lot of those patients may not have been immobilized correctly. So this is part of the reason we are moving to spinal motion restriction versus the traditional spinal immobilization. Spinal motion restriction still requires ongoing assessments, in fact, probably more than before, which does include motor and sensory function, just as we've done with our backboarding. It is crucial that you ensure the patient understands what you want to do and not to do in this process. Explain the process to them and make sure they understand it, just like we did when we were on a KED or a long backboard or any other device. Let's review the protocol, and then we'll discuss some of the ways we're going to utilize spinal motion restriction in some of our more common scenarios. Substantial changes here. This section pertains to those patients with penetrating trauma, the major trauma protocol, or those patients with trauma not meeting the major trauma protocol. So no changes here in this section to the current protocol. Next, we've got 6 criteria that we're going to look at. The first one is altered mental state. A patient with a Glasgow Coma scale below 15, that would be a positive finding. There's a lot of discussion. There's been a lot of discussion in research, PHTLS, and other places about whether or not to use a GCS of 14. But the committee really looked at it and wanted to keep it at 15. So it's a patient, again, using common sense. If you come up to them and as they're closed and they're just resting, that doesn't mean that they're a GCS of 14. As long as they're able to communicate with you, they could be a GCS of 15. So we're really looking at anybody who's below a 15. Or number 2, a complaint of neck or spine pain or tenderness. Weakness, tingling, or numbness of the trunk or extremities at any time after the injury. So this is not something that they would have had prior to this incident. This is something new that's happened. They have conditions before the incident, and then the incident actually aggravated it, which did cause some numbness and tingling or loss of movement. Number 4 is deformity of the spine that was not present prior to the injury or incident. And number 5, the big one, distracting injury or circumstances. Distracting injuries are very subjective for EMS providers to determine. What is distracting to the patient may not be distracting to you or I, especially in that moment. Distracting injuries are usually any injury, physical or emotional, that takes the patient's attention away from another injury that the EMS provider is more concerned with. So even the trauma of the event cause attacking to what injury is. So it doesn't just have to be a specific injury, it could be the event itself. We've seen patients can walk around with fractured arms and be very little pain because they're in shock. So you look at those, plus the 6th one here, high risk mechanism of injury associated with unstable spinal injuries that include, or limited to, are axial load injuries, which are usually your diving accidents or spear tackle sporting injuries in like football or soccer. Vehicle crashes, they're dependent on many factors, including the type of the vehicle, the safety accessories, what was up, etc. Then bicycle collisions, which have similar subjective issues, such as the speed of the vehicles, what they actually hit. And also a fall of more than 3 feet or approximately 5 stairs, or patient's height. It's dependent on other factors as well, but these can all be used as general guidelines. So we're looking at all 6 of these things within the protocol. If an injury is suspected, the patient should be placed in a properly fitted, rigid cervical collar and spinal movement minimized. It's without any of the above findings, 1 through 6, may be transported without the use of a cervical collar or any other means to restrict spinal movement without the use of a backboard. So meet any of the criteria 1 through 6, you can put a collar on and collar unless there's other circumstances where you have to use a long board, which we'll discuss later. And if they don't have any of those items 1 through 6, you don't even need to put the collar on. Somebody did ask a question here about patient. That's a very, very good question. And it really depends on their extent of dementia, whether or not they're alert to things around them. Err on the safe side with those patients and at least put them in a collar. Again, we're not going to be immobilizing them on a long board like we do traditionally, but probably the use of a collar would be good. Again, it depends on the patient and the extent of their dementia. Shortboard devices are still utilized, but as extrication and moving devices, not as transportation devices. Motion restriction can be accomplished for some patients only a cervical collar and securing them to the ambulance stretcher. Yet again, this does mean that you may be arriving at the hospital with somebody in a cervical collar with no backboard, just on your sheets and blankets in the ambulance. It must be used by higher level care providers who arrive on the scene and spinal motion restriction has already been initiated. They feel that it's not necessary. For example, if a FAR EMT is first and the paramedic comes in and the EMT or CFR has already started spinal motion restriction, there should be a discussion between the two of them if and whether it needs to be continued. If the first EMS provider found it necessary to begin spinal motion restriction, both of you should get together to discuss why it was initiated and how to proceed along with a thorough patient assessment. Don't just come in and say, we need that, let's stop that, and hold immobilization and spinal motion restriction. They can get up and get on the stretcher. Discuss it first. The level of care provider who feels spinal motion restriction should be stopped should also be the provider who accompanies the patient to the hospital. They should be fully documented as to the start and cessation of spinal motion restriction. Bringing a patient from one hospital to another hospital and they are already on a backboard, the EMS provider in charge should discuss with the sending physician to use spinal motion restriction instead of spinal immobilization. However, the sending physician is in charge of that patient and the treatment for that patient. So if that sending physician wants the patient left on the long board, they're going to have to leave them on the long board. But should discuss the optional use of spinal motion restriction to get them off of the backboard because the prolonged use of the backboard, again, can be very detrimental to a lot of our patients. Here we have a quick video. And this will be just like before. You may have the audio off a little bit from the video, but it's discussing the proper sizing and application of the cervical collar, which we tend to be a little bit off of sometimes. I think we've all seen providers just slap a collar on without measuring it.
This breaks the technique of measuring, sizing, and applying a cervical collar. While the video shows a particular brand of cervical collar for demonstration purposes, the principles of sizing and application remain the same regardless of the product chosen for use by an individual service. It is the responsibility of each provider to be familiar with the specifics of the product in use in his or her service. The provider initiates manual neutral inline stabilization of the patient's head and neck. The provider uses his or her fingers to measure the distance between the patient's lower jaw and shoulder. Uses this measurement to select a properly sized collar, or to an adjustable collar to the correct size. If an adjustable collar is used, the provider must make sure the collar is locked into the proper size. The second applies the properly sized collar, while the first provider maintains the neutral inline head and neck stabilization until the patient is secured to an immobilization device. Populations, such as extremes of age and size, may require additional padding and support to maintain adequate alignment and comfort.
So basic on instructions on how to put a rigid cervical collar in place. You may have patients who are obese, or pediatric patients even, that you don't have a properly sized collar for. So you have to be prepared to utilize either some towels to wrap around the patient's neck or head area to try and immobilize it. But overall, you really saw no difference in this video than what we're going to be doing under this new protocol. You're still going to be stabilizing the head, just as we did for the traditional immobilization, and put the collar on. But we're just calling it spinal motion restriction and collar in place. And that collar is going to aid in the patient really self-administering spinal motion restriction. You have asked questions on here, and most of those questions are going to be answered later on throughout the presentation. But if they're not, then you can just ask them again at the end. But no matter what kind of collar you're using, it should be a rigid cervical collar. You've got to read instructions from the manufacturer. You have to know the exact way that they want it measured to place on your patient. It sounds pretty easy, but you'd be surprised what you may find in the manufacturer's instructions for these items. So this is the protocol here. This is the approved protocol, and we're going to go through each step. As you can see, the protocol is in a flowchart format. We'll work on cleaning up all the current protocols, and as we move them forward, we're going to be producing them in flowchart format as much as we can. There are some protocols we can't do that with, but we're going to try and clean these up and make them a little bit more user-friendly these days. Here, does the patient meet the adult major trauma criteria with blunt mechanism of injury, like T6 or T7? Get on to that, either yes or no. If yes, go down the left side. Spine injury should be suspected, and the patient should be placed in a properly fitted cervical collar and spinal movement minimized. If no, it's when we move into our 6 criteria and things such as altered mental state, complete neck or back pain, weakness, tingling, or numbness in the trunk or extremities, deformity of the spinal column, distracting injuries, and then again our mechanism of injury and the risk mechanism of injuries. And a lot of this is subjective except for the signs and symptoms they're going to see in these 6 items. But you notice, again, mechanism of injury is step number 6, where prior to even 2008, it was always the first step. We were planning the mechanisms of injury and looking more at what we're finding during your assessment and what the patient's complaints are. Now, there, what they do or they don't have any of these 6 items. If they don't, patients without any of the above findings may be transported without the use of a collar or other means to restrict spinal motion. So very simple, very straightforward. Everything that we said earlier is just in a flowchart format. And at the bottom, you've got a note box here which talks about most of the items we already discussed. If you look through here, we've got, again, spinal movement can be minimized by application of a properly fitted rigid ankle collar and carrying the patient to the stretcher, which we'll talk more about in a little while. And all of these items on here already, so I'm not going to repeat them. The long spine board, as it says here, is next to last bullet. Only one of multiple modalities that can be utilized to minimize spinal movement. Not to use a long spine board will not constitute a deviation from the standard of care. Standard of care is what you're taught and what current protocol is. Just go by your current protocol. You're within your standard of care that you're certified under. A bit about some high-risk patients that may make it a little bit more difficult for us. We need to be able to know who high-risk patients are for spinal injuries. So any patient with a disease or an illness that affects bone structure and or density, they are higher risk for spinal fractures. Geriatric patients to have lower bone densities as well as some curvature of the spinal column. Patients who have osteoporosis have weaker and more brittle bones. With a genetic disorder, trisomy 21, which is Down syndrome, have likelihood of having decreased stability in the function of cervical vertebrae C1 and C2, your vertebrae in your neck. It can lead to increased risk for fractures in the area of C1 and C2. This is found more often in children than adults. The picture on the slide shows a patient with an instability and injury at the junction of C1 and C2. The patient who does have Down syndrome. Usually these at-risk patients tend to have non-displaced fractures, but no obliques. Fractures are compression-type fractures. They're not disc fractures, as we see here on the left side of the screen. Usually does a patient, we'll go back one. Where does a patient have a displaced fracture, they're enough to cause a spinal cord injury, as we can see in the X-ray on the right-hand side of the screen. So, really, if this was your patient, immobilizing the patient on a long backboard with a compression fracture wouldn't do much for that patient. Now, spinal motion restriction and reducing gross movement is going to prevent further injury and also make the patient more comfortable and be able to stay in a position of more comfort and lessening the pain. Patient right, again, it is so rare that we will find a patient with a displacement like this that's not just a compression fracture, that spinal motion restriction should be utilized, and just extra care if we do find numbness, tingle, and so forth to the remedies. How do you handle your patients who are found standing or walking around? Standing takedown is no longer utilized for patients found in the standing position. Taken to initiate and maintain spinal motion restriction when appropriate. Application of a rigid cervical collar should be completed prior to moving the patient. The patient should be assisted to the stretcher and properly secured to the stretcher following your stretcher manufacturer's instructions. So let's discuss some of the more common ways you will find your patients and how you're going to deal with those patients. When you find your patient in a standing position, you still need to communicate with them as to what you're going to do. You are assisting the patient with spinal motion restriction of their head and neck at this point. And hold manual cervical stabilization of the head and neck, then place the patient in the appropriate size cervical collar, as you see here in these pictures. So really no change from what we're used to from before. The stretcher behind the patient, there is limited movement of the patient to get him onto the stretcher. This is where our first big change is going to occur. No longer doing a standing takedown, no longer laying them on a backboard. We'll allow them and assist them to sit down and try to restrict their spinal movement as much as possible. So it's your patient to sit on the stretcher while maintaining spinal motion restriction, depending on your patient, the ability to follow directions appropriately, and of course your assessment findings, all will play a role in how much assistance you will need to give your patient to get them onto the stretcher. For example, a patient with signs of a concussion need to have instructions repeated to them and additional assistance to have them sit down on the stretcher. So really assisting your patient to get on the stretcher, holding the patient's head will assist in maintaining spinal motion restriction. Some patients may not need you to hold their head, and some may need to help them, but it really depends on your patient. Most patients with neck or back pain are going to self-split themselves and reduce the motion anyways. Try to keep your patient from bending their spinal column, maintaining spinal motion restriction while laying them down. Patients will probably be more comfortable in a sitting position using a 45 or 90 degree angle. Patient and circumstance will be different. At times it may not be necessary to lay your patient down to a full supine position. In fact, that could be doing them more harm. It makes it more difficult to breathe and increases pain on the injury sites. So many of these patients will be sitting up at a 45 or 90 degree angle in a collar, no backboard, when they arrive at the hospital. The patient is laying on the stretcher, you can stop holding the head, but you still need to instruct the patient to not move their head and try to remain still as possible. There's manufacturer's guidelines plus stretcher safety belts on the patient. You see here on these pictures, this stretcher comes with a harness type safety belt for the upper body. It will not only improve patient safety, but also help in maintaining spinal motion restriction by limiting how the patient can move. Seated patients. First thing is to manually stabilize the cervical spine and explain to the patient what you're going to do, just as we did before, and apply the appropriately sized cervical collar. I think you can understand the theme that's going on here. As long as your assessment doesn't reveal injuries or disentanglement issues, you can assist the patient from their seated position, like a chair or a car seat, to the stretcher, but you need to maintain spinal motion restriction to limit gross movement of the patient's spine. Short devices can be used, but only for safely moving a patient while maintaining spinal motion restriction. In some instances, like extensive damage to the vehicle, altered mental status, or patient intoxication, it might be better to place them in a shortboard device because they can't safely remove themselves from their environment without moving their spinal column. A long backboard can be utilized as a slide board or to move the patient from their current seated position to the ambulance stretcher. The patient should not be transported on the long backboard. If possible, you can remove the patient from the seated position directly to the ambulance stretcher without the use of a long board, which we'll discuss in a little bit. Each patient and circumstance, again, is going to be different. But if the patient has an isolated neck injury, it might be possible to have the patient sitting up on the stretcher at a 45 or 90 degree angle with a collar in place and transporting them that way. Your call for your patient is spinal motion restriction is maintained. So patient in a seated position, let's say against an object such as a wall, you will need to begin holding the head from the front. So you're holding head stabilization from the front of the patient. Depending on your patient and their circumstances, they may be able to stand up with a little assistance from you or on their own. For some patients may need additional help not only from 2 or more providers, but to the use of a shortboard device, such as we see here with the KED. In this situation, the KED was applied as it normally would, which provides handles for the EMS provider to grasp and to assist them in standing the patient in an upright position. It would be a useful technique for a patient, again, with altered mental state. This device should be removed from the patient. It should not be transported in a shortboard device unless it's absolutely necessary. Once you lay them on the stretcher, you can loosen and remove all straps and the device, the head and the chest area, as well as the pelvic Slide the device from behind the patient while maintaining spinal motion restriction. Another option is to remove the device while the patient is standing in the same position and before they actually place the stretcher. But it really depends on whether or not the patient is alert enough and can stand, and you can safely remove it before you get on the stretcher. Sitting in a chair is a little bit easier to handle, of course. You can hold manual stabilization of the cervical spine from the patient's posterior side, place appropriately sized cervical collar, and assist the patient to the standing position. In these pictures, the patient needed quite a bit of assistance through the use of an EMS provider on each side of the patient. Patients will probably only need one provider to assist them, but each circumstance, again, is going to be different. But don't be afraid to use a couple providers just to assist them in standing so they don't move around too much. Blood crashes have additional challenges for us, just as they have when we utilize the traditional spinal immobilization techniques. Remember, the goal is to reduce movement of the patient's spinal column. Keep that in mind when you develop your plan for removing the patient from the vehicle. Really stabilize the cervical spine and apply the appropriate cervical collar. As you see in this picture, I'm sitting in the back seat, was able to place the collar on and stabilization. Patients may be able to self-extricate from the vehicle with little assistance from EMS providers, but you still need to make sure the patient is limiting movement of their spinal column. As we see here, cervical stabilization is transferred to the EMS provider standing outside and in front of the vehicle, in front of the patient as they swing their legs out of the vehicle. Third picture, you see that this vehicle has a very low roof line, and the patient almost needs to bend forward to stand up the vehicle. Try to avoid this so you can maintain spinal motion restriction as best as possible. So there may still be a circumstance, depending on the patient and the damage to the vehicle, where you still may need to take the roof off because it's such a small compartment area and a low roof line, you can't even stand them up without and bend their upper back or even their neck. Standing up outside of the vehicle, assist them to the stretcher and lay down as we discussed earlier. Each patient is going to be a little bit different how much assistance we're going to need. Not self-extricate or end up with assistance. You need to remove them from the vehicle in a more traditional way. Here we stretcher placed up against the vehicle, and the patient is slid longitudinally out of the vehicle and on the stretcher. One problem you will most likely have with this technique is that sheets of the blankets on the stretcher will slide too much, and you won't have enough of them under the patient to safely transfer them when you get to the hospital. The blankets will also cause additional friction that will make your job even more difficult to move the patient. Another way to remove the patient from the vehicle is to utilize a long backboard. In this technique, the long backboard is utilized more as a slide board device and not an immobilization device. In this scenario, the long backboard is placed on the patient's buttocks, and the patient is guided out of the vehicle to sit on the long backboard and then down onto the long board. Again, the patient is then laid down on the long backboard and slid up to the top of the board. Now you can either slide the patient from the long board and on the stretcher, as you see here, discussed in the next slide, backboard on the stretcher as you have normally done with traditional spinal mobilization. We'll discuss how you remove the patient from the long board and transfer them at the hospital in a minute. Find patients, those patients found laying on their back. Again, you'll stabilize the cervical spine, apply the appropriately sized cervical collar, and there's numerous ways to move a patient from the supine position to the stretcher. Patient encounter will be different, and which device you decide to use is dependent on your routine survey and patient assessment. One of the easiest devices to use is a scoop-type stretcher. This allows you to move the patient as a sub-unit while maintaining spinal motion restriction. Long boards, sheet moves, lift carry moves, log rolls could also be used. You make the call based on what you see and are able to do while maintaining spinal motion restriction. are those patients who are found in a face-down position, or our lateral recumbent patients, those patients found laying down on their left or right side. Same thing goes here. Manually stabilize, apply the appropriately sized cervical collar, and as with the supine patient, there is no one single way to accomplish getting your patient onto the stretcher. Log rolling the patient onto a longboard may be the easiest, safest, and quickest way to do it. You can log roll the patient and utilize the scoop stretcher. Again, as long as you can safely move the patient while maintaining spinal motion restriction, you should be fine. You'll need to make the call for each circumstance that you have. Here are some examples of scoop-type stretchers. Scoop stretcher is ideal for moving a supine patient from one point to another. It can be split in half, placed around the patient, secured, and then the patient lifted while maintaining spinal motion restriction, with very little, if any, movement of the patient. However, care needs to be taken to follow the device's manufacturer guidelines for these and the securing of the patient to the device. Before falling out of favor a year ago, the scoop was used to be a line device for many patient modes, especially patients with fractured hips. This is one reason they are also called orthopedic stretchers. For those of you who have been around for a long time, you probably remember when we used the scoop stretchers before we even had backboards. For transport times, you could leave the patient on the scoop stretcher during the transport by assisting in moving the patient from the ambulance stretcher to the hospital stretcher while maintaining spinal motion restriction. For long transport times, it may be better for the patient to be removed from the scoop and then reapplied at the hospital or utilize a traditional sheet move as long as spinal motion restriction can be attained. You need to follow your manufacturer's guidelines for use. Portion of the training, you'll review the different components of a scoop stretcher, as well as demonstrate how it is used according to the manufacturer guidelines for that specific device. There's a lot of newer type stretchers out there these days, and you got to make sure that you understand how that manufacturer wants you to utilize that particular scoop stretcher. There's many different ones out there. Vacuum splints are another device that can be utilized to transport patients while maintaining spinal motion restriction. However, it may not be the most appropriate device depending on the patient's injuries, condition, and ongoing assessment needs. To get the patient in this device, you may not be able to adequately reassess and do an ongoing assessment of the back of the patient or the transporting spinal injury patients on long backboards. What happens when you decide that the best way to move a patient from point A to your stretcher is by placing them on a longboard? How do you remove the patient from the long backboard? There's a solution that fits every situation. However, some of these techniques on the slide that you see here could be useful. Every MT course teaches proper lifting, moving techniques, which can be used as the basis for these techniques. Each technique shown here has its pluses and minuses. This is why you need to practice different techniques in different situations to determine what works best for you and the patient for the environment that you're in. I see the crew utilizing the log roll technique to remove the long backboard from the patient when the long backboard is placed on the stretcher. This technique is not suggested for all patients. Our stretchers are very narrow, which makes it difficult to utilize this technique, especially for larger patients. But the patient was small enough to allow the log roll technique to be utilized safely and remove the long backboard. The technique is to hold the patient in place and slide the long backboard out from under the patient. This is something that you can do in the back of an ambulance, so think ahead of time and do this prior to loading the patient in the ambulance. Learn with traditional spinal mobilization, you need to add padding to fill voids, especially with the elderly patients. This holds true when utilizing spinal motion restriction when you place the patient on your stretcher. I think we'd all be in agreement that our stretcher pads are not very soft, and they're conforming to all the patient voids. Even if the patient does not have kyphosis or curvature of the spine, they will most likely need some degree of padding. Stretcher patients will most likely require about an inch of padding between their torso and stretcher as seen here in these pictures. Remember, children tend to have larger occipital regions of their skull than adults do, which causes flexion of their head and neck and could cause airway issues, not to mention increased risk for cervical spinal injury. Stretcher use. You need to know what your stretcher manufacturer's requirements are for properly securing your patient to that stretcher. When utilizing spinal motion restriction properly, securing your patient to the stretcher is crucial. Improperly securing your patient to the stretcher not only places the patient at risk for further injury, restrictiveness of spinal motion restriction, but you may be liable if not followed the manufacturer's requirements for safely belting the patient in. Now, what happens when you get to the hospital? Well, moving the patient on a long backboard from your stretcher to the hospital stretcher is much easier to maintain spinal motion restriction on a long backboard. It's easier, it's quicker, and kind of what we're used to. Great care needs to be taken when transferring patients from your stretcher to the hospital stretcher when you don't have the luck of having a long backboard there. Moving patients is a new skill that we all need to learn and practice. The lifting moving techniques we were taught during the EMT school did not take into consideration spinal motion restriction. This is why you need to practice the skill and plan ahead with every patient transfer to ensure you properly move the patient while maintaining spinal motion restriction. Transfer, you still must keep spinal motion restriction in place. The patient has to be moved as a unit. There's no single transfer maneuver that fits every patient or every situation. However, there are some common techniques that can be used on all of your patients. Friction reduction devices can make your transfer go much more smoothly. On this pictures here, these are some examples of some commercially made slide boards, also known as friction reducing devices. As you can see in the picture on the left of the screen, the slide board straddles both beds, but there is no gap in between the beds. Slide boards should not be used to bridge a gap between two bed stretchers. Hospitals, especially the radiology departments, have used slide boards for a very long time. And I've seen slide boards in the emergency room. Reach the hospital, you should have already had a plan in mind of how you're going to transfer your patient. That plan is knowing how many people you will need to appropriately transfer the patient while still maintaining spinal motion restriction. A minimum of 3 people should be involved in the transfer. One at the patient's head, one on the patient's left side, and one on the patient's right side. Just we learned when we log roll a patient onto a long backboard, this is a team effort just for these patients. Having the adequate number of people to assist in the transfer will assure a safe transfer. Fail to plan ahead and have enough help could cause low spinal motion restriction, causing pain and or injury to the patient, and or injury to EMS personnel and others who are assisting in the transfer. Finally, you need to assure that both stretchers are at the proper height, but they should have a height that works for everyone on the transfer team to assure proper body mechanics during the transfer. Let gravity work in your favor. Keep your stretcher slightly higher than the hospital stretcher for the transfer. Reap assistance if necessary. Just because somebody's in the wrong spot doesn't mean you should keep them there. Make sure everybody is in the correct position. Keep your body stacked and straight. Twists and awkward positions of your body. Keep the weight as close to your body as possible when preparing to move the patient. Neck muscles to lift or move the patient. And reach more than 15 to 20 inches in front of your body. So if you're utilizing a sheet move, you need to ensure that the sheet is nice and taut and tight under the patient. So rolling the sheet up to make it nice and close to the patient, and that way bringing the patient's weight closer to your body. And if the sheet is nice and tight underneath the patient, you should have a good, smooth transfer of the patient. As we were taught where to place the backboard straps on the patient's body, the same goes for transferring the patient. Your hands are on the patient's head, shoulders, hips, and knees will help you to move the patient as a unit. picture, we see how staff is transferring the patient using a slide board and proper lifting and sliding technique. The patient is transferred as one unit. Now, one provider is managing the patient's head, while the provider is on each side of the patient, at the shoulder and the hips. There is an additional provider who is off screen at the feet, and he's assisting with the moving of the patient's legs. On the picture on the left is showing a proper transfer technique with 3 people on the side they are moving the patient towards, and 2 on the side where the patient being moved from. On the right is, of course, a poor technique, not because he is reaching to do it himself, but reaching too far in front of her and setting herself up for a back injury, and the patient possibly rolling away from her and off of the stretcher. Now, this portion is going to be done locally. We find the skills portion to be done by a New York State IC, CLA, or a medical director in some cases. State certified instructors have the education and background to develop classes and curricula to be implemented locally to meet their local needs. Those who do not have a readily available CIC or CLI should reach out to their respective regional EMS councils or sponsor in finding the appropriate instruction staff. Those, again, who are affiliated themselves with the CIC for their CME renewal program should reach out to that CIC first. This skill is a huge change with no one single perfect sequence to complete. There will be variations at the local level. The repeated practice for many of us to get the skill down and be able to adapt it for changing conditions and environment that we find our patients in. Records for all the providers who receive the training must be documented and kept on file at the agency level or at the regional level, wherever the training is going to be done. Again, the New York State Practical Skills Exam will not be changing at this time. Maybe making some future changes to the Practical Skills Exam, but so they're really trying to stay with the national model of the current standards and national registry skills stations. We aren't going to make a move until they do or we develop something a little bit different for New York. We hope that this webinar was helpful to you and that it's easier for you to obtain the information. This is the time we've done this type of statewide training. We hope to continue and improve the ways we can get the information out to you, the provider, the instructor, and all of the other EMS entities that we need to reach out to. Make sure that you individually register for either this webinar or the recorded version, and log into the WebEx to complete your 25-question assessment for this webinar. You'll receive email again from WebEx with your grade. Hold on to that because you need to file that and prove that you did attend and pass the quiz. You'll also receive a certificate of completion from the State Bureau of EMS for hours of CME. That's in consideration tonight's webinar and the skills portion that you're going to be doing locally. And the certificates should hopefully be out in the early part of September once everybody is pretty much with this. So thanks for attending tonight. I know you've all got very busy lives, and there's been some great questions back and forth. And I encourage anybody, if they want to ask questions now, they can. And if you want to stay and listen to some of the questions and answers, that's free to. If not, bid you a farewell and have a good evening and stay safe out there. For those of you that want to stay for a little bit, I will take some questions here for a little while. The protocol take effect. Have this done by October 30th. If your agency has everybody done before that, then your agency can go online with the new protocol. You don't have to wait until October 30th or November to actually start. It's also up to your agency's medical director and your training officer at your agency to determine if everybody's all set to go, and if you are, go ahead using it. Any other questions or anything that we didn't cover during the webinar? Webinar or a separate webinar will be recorded, and we're going to send out the link to the recording so that people that couldn't register for tonight or any of the future webinars can watch it anytime, anywhere. somebody asked, did we show a prone patient? We didn't actually show one on the screen. We did talk about the prone patient and log rolling them into the supine position and utilizing a scoop stretcher or long backboard to move them onto the ambulance stretcher. Somebody asked, do head blocks still have a use? As of right now, probably not. But there are some questions the tag is going to have to answer, like how do you continually stabilize the patient's head if they're intoxicated, also the level of consciousness while they're on the stretcher and during transport. If you don't have the luxury of having a second provider to be able to hold stabilization, you might be looking at some way of possibly using those head blocks and securing them to the stretcher a little bit to improve the restriction of the motion of the patient during transport, and then releasing them while you're holding stabilization once you get to the hospital. But right now, they haven't discussed really too much what to do with the head immobilizers. Yes, this does take effect in October. I often hear providers say immobilize if in doubt. It's better err on the side of caution. Well, the side of caution is now just the opposite. You suspect spinal injury, spinal motion restriction, according to your protocol, is sufficient enough. You actually cause more harm by placing a patient on a long backboard and having them left on there to transport in the hospital. So that was really the issue with the 2008 protocol as well, is people would say, well, I'm going to err on the side of caution and just put them on board. Now the error on the side of caution is putting them on a collar and restricting their movement. Ask, will transport in a recumbent position allowed? Yes, if your patient can sit at a 45 or 90 degree angle or whatever angle is comfortable for them, that's appropriate. Again, depending on the patient, the situation, and your assessment findings. I think I answered that one already, but manual stabilization the entire time, even after the collar is applied, usually not. Again, depends on your patient. If they're able to follow directions and they're alert enough, one collar on, you should be able to let go of the head, because the collar is actually going to be taking the place of what your hands were doing and reducing the motion of the neck. I believe it's Edgar asked, what about the individuals who become certified as EMTs after this deadline? This information is going to be incorporated into their courses. And the state written exam will have very few changes in it. There's really very little transition that we're going to have to do, but we will have to change some of the items that are on the certification exams, written exam, but for the most part, everybody will be fine with that. You cannot get the protocol off of the course materials, or you cannot get to the link for the course materials, feel free to email me through the registration email that you found, and I will get that to you. If password for the test, for the quiz, it might be Spinal 2015, all one word. Spinal 2015. I think there was and I'll double check that. If you have difficulty getting into that, let me know or send me an email and I'll double check that. Question here, do you know if the hospital staff are being educated on this change for EMS? We talked a little bit about that, and that's going to be a very long-term process that's going to need to be done at the regional and local level. Even though Health Department, it's difficult because the Bureau of EMS doesn't regulate hospitals and emergency departments. But through our STOM Advisory Council, through our regional EMS councils, our program agencies, they're getting the words out more locally to the emergency departments, especially the trauma centers, of how this is going to be rolled out and what to expect from EMS. I think for the most part, be accepted very quickly as trauma centers. But when we started backboarding, I'm sure somebody is going to be upset because you didn't use a backboard now instead of using one. But again, stick with your protocol. As long as you treat your patient according to your protocol and what you're educated for that protocol, you're good. And if the hospital still gives you a really hard time, I would refer them to your medical director or have your medical director for your agency contact them and discuss it. And if it's a widespread issue with one or more hospitals in your region, hold of your regional council and your REMAC and discuss it with them so they can discuss it more locally. Asked about firefighters as well. This takes effect for anybody who's certified in New York State, ALS or BLS. To be updated to this protocol if they are not able to attend one of these webinar sessions. Hopefully they'll be, if they can't get on one of these sessions, the live sessions, they should be able to get on to the recorded one once we send that link out, and that can be done at any time and anywhere. So hopefully we can do it via the recorded message one, the recorded session that can also be downloaded to locally to your computer. I know there are some places that say that a lot of their people may not have internet access. I recommend going to the agency because most all agencies have internet access now. And if that's not possible, try to find someone who can download it and save it for you. But you will also get it in your renewal courses as well as the original courses. If you quiz, you should be able to get to it once you leave this webinar and or go back into it via the link to get into the webinar. And you should be able to find it there. You should also receive another email today, and you probably get one that give a link directly to the quiz as well. Questions that came up during the first webinar regarding the patient who's on a traction split now. And that's a very good question. That was something that I don't think really looked at yet. We're going to be discussing that more as we move forward with this new protocol. And there are going to be some patients that, you know what, it's going to be easier for you to put on a long backboard. For example, a patient who was struck by a motor vehicle and has multiple extremity fractures, and if you're not able to get them into a scoop, it's easier on a long board at that point. But for the most part, 98 to 99% of our patients won't need backboard to be transported on anyway. What happens if you don't pass the quiz? You get 3 attempts at it. Please refer back to the PDF document, the PowerPoint, so you can find information in there. You can utilize that during the quiz. That's perfectly fine. And if you wait till the recorded session, you can play that back as well. But you've got 3 attempts to do it, and I think everybody should be able to get through it in 3 attempts. If not, then you're just going to need to register for the recorded version and then retake the quiz again. You don't have to watch it if you don't want to, but if you fail the quiz 3 times, you probably should watch it on the recorded version and then take 3 attempts at that quiz. You'll have a minimum of 2 weeks to get the quiz done for tonight's webinar, and anytime you register for a future webinar, it's 2 weeks at least after that. So, well, and we end the time if needed, but we wanted to try and get everybody done in 2 weeks if possible. If you have any questions, or if I missed any of the questions, because some of them are going by pretty quick here. About handling combative head injured patients. It'll be very difficult. We just put out some literature on traumatic brain injury in patients, but if you've got a patient who is violent, they may need sedation from an ALS service, or putting them on a longboard and strapping them down can be more detrimental than them being a little bit combative. You may have to restrain their extremities, try to limit their motion as best as possible, but there's no one-size-fits-all with this. It's going to be different for every situation. I really hope that this webinar was good for you guys. I hope that it was a new way to get the information out there in a more uniform way and reducing some of the impact on the local instructors and the agencies to have to set up individual sessions and get everybody trained. So hopefully this does help you guys a lot. Again, we had some bumps in the road with the first one. It's like this one went off pretty well. Some people had some issues with audio, but for the most part, everybody did pretty well, I think, with the audio on this one. And it went very well. Hopefully the groups that are watching out, like Good Sam and other places, were able to get through this okay without any technical issues. Again, we hope as we move forward here with what limitations we do have at the state, I'm really trying to find new ways to get this information out to you guys. And with 60,000 providers in the state, that can be a little tough at times. But does anybody else have any other questions? We still got about 130 people left. Yeah, well, and I was actually thinking about adding some more scenario type and things, but I also didn't want to make this too long of a presentation. I wanted to try and keep it as close to an hour and a half as possible, and not go on and on forever. And really, a lot of it is going to depend on situation and a lot of practice on your part as a provider, and see what different we can keep restriction in place for patients. It's all the time at your skill stations. Again, the skill station should be like scenarios where an instructor is helping you, and it's really getting all of your minds together to come up with the best plan to get the patient from point A to point B with maintaining spinal motion restriction. It's not you're holding a whip and a chair over you to make sure you do A, B, C, D, and E. It can be done a lot of different ways. You have to be creative. Everything's different. There's a one size fits all. I guess I had some audio problems. I'll repeat the information about the protocol and the practical skills and the written. Everybody has to be up on this by October 30th. If your AC has everybody on board with this before October 30th, they can start utilizing the protocol. The practical skills exam is not going to change at this point. We may make some changes down the road, but for the most part, you're still going to have to know how to put a patient in a shortboard and a longboard device for carrying purposes and moving from point A to point B. You're just not going to be transporting them on those devices. The exam has very few changes in it, and they'll be ready after the September exam, or for the September exam, excuse me. But even if we have a disaster or something, we don't get to it, the questions that are there now are pretty simple, and nobody's going to have an issue whether they've had the update or they haven't had the update. Is required. Should be done locally by your CIC or CLR training officer, medical director if possible, and that is required. You should get that done before October 30th. You can watch the webinar, take the quiz, and then have the skill session locally whenever it fits your guys' needs locally. If you're finding that nobody else can register for the sessions because they're full, we're going to send out a link for a recorded version. It might be this evening's version that we're going to send out, and people can just register to watch the recorded version at any time, any place, and then take the quiz that's going to be attached to the recorded version. The test for the skills portion, the skill sheets, again, are just a complete sheet to make sure that you guys have run through it locally and you've your heads together to work from patient scenarios. Again, a heavy testing environment for the skills portion. It's really one way to do it, so we make it as laid back and educational as possible for you guys at the local level. Now, what happens if you have an instructor that's a little overzealous? Well, not too much we can do about that, but hopefully it'll go well to the local level. Do you have any questions here? You know what, the skill session, you can do it tonight or anytime in the next 2 weeks. Any other questions coming up right now about the recorded version? We're going to email that out, and my hope is to get it up onto our Bureau of EMS website. That usually takes an act of God and a while to do. That's why I wanted to get it emailed out to you guys as we get it done. But that's the plan, to put it up on our website so you can have access to it there and everybody can find it there. But we're going to link out to the world and the serve that we own. before we probably will get approval to get it up on the website. All right, knowing that we are 8. I don't see any other questions coming through. Again, I hope it's informative for you, and it was a good way to get the information out to you. We do look forward to your constructive feedback. If you have any suggestions for us or good or bad points about it, please feel free to email me. And we do really how you guys feel about doing this type of training, and hopefully this is a new way we can do things for you guys to make it more flexible and easier for everybody out in the field. So if no other questions, since we're getting kind of late, and we still have work to do here and then head home tonight, I will bid you all a farewell. Please for the evening, and stay safe out there, and enjoy your patients. Take it, buddy. Thank you, and